right. Welcome to the OuchCast, everyone. My name is Neal Rakesh, and today we have a couple special guests, Dr. Anjum Bucks and Dr. Amitabh Gulati, and they're going to talk to us today about intrathecal drug delivery. If you guys want to talk to us a little bit about yourselves and kind of your expertise in this field.
Yeah, I'll start first. This is Dr. Anjum Bucks. I am a interventional pain physician based out of Kentucky. I've been practicing about 18 years. We have about 600 pain pumps under management. So I've been doing targeted drug delivery really for about 12, 13 years now.
Hello, I'm Amitabh Gulati. I'm one of the physicians at Memorial Sloan Kettering Cancer Center in New York City. I've been practicing for about 15 years, having the opportunity to work with our patients who are suffering from cancer pain. And clearly, intrathecal drug delivery plays a very prominent role in managing these patients. And we have some very successful stories about how we can help some of our patients who are suffering from cancer-related issues.
So let's start at the basics, because not every one of the listeners is going to understand all of this stuff. Some of the people may be residents, fellows. What exactly is intrathecal drug delivery systems? What does that mean functionally?
You know, the way I explain it to my patients is really, any of the oral medications they're taking, any of the oral opioids they're taking, it's like crushing it up, putting it in a tube, and delivering it to the spinal fluid, where the source of their pain is, whether it's neck pain or low back pain. Basically, intrathecal drug delivery system is an alternate route of delivery of medication, whether it be opioid or non-opioid. You're delivering it to the spinal fluid. You get better pain relief with less medication. There's some roundabout numbers there. It could be 300 times stronger than the pain pill they're taking. Yeah. But less side effects and better pain relief delivering to the spinal fluid.
What do your patients say when they say delivering to the spinal fluid? Do they freak out about that? How do you make that easier for them to conceptualize and kind of ease into that process? Because before they're taking medications, and now you're saying I'm going to implant something in them and it's going into spinal fluid. That sounds pretty crazy. Right.
But a lot of these patients come in and they're not getting pain relief with the oral medications they're taking. So they're coming in to us hurting. They're coming in saying whatever I'm doing is not working. So really, what I'm offering them is we're going to, put the pain medication to the source of the pain. So we're delivering pain medication to the source of the pain, and they're open to that.
That makes sense. Now, you both talked about this. So you operate kind of in the non-cancer world, and you operate in the cancer world. So there's different patients that you look at, indications for that. If you had the ideal patient in the entire world, what is it that you're looking for specifically that says this is an intrathecal drug delivery patient?
For the patients who are suffering from cancer-related pain, what we really see is that if you're taking an opioid for pain, but it's causing a side effect, so you can't be with your family, you can't enjoy the quality of life, but the opioid did help with pain, then the intrathecal pump will be really helpful. What you'll see is that they'll get the pain relief with that device, but they get to be more themselves. They'll be more awake, they'll be less constipated, less nausea, perhaps even healthier, such that they can have the energy to fight their cancer. And so a lot of these things have been shown already in the literature, and this is really what is the most beneficial patient. The patients that will benefit the most tend to have opioid-related side effects, but the opioid is helpful for pain relief.
Yeah. What about you, Anjum?
So in the non-cancer population, again, we're looking for improvement of quality of life. These are patients that have increasing neck pain, low back pain. The ideal patient really is one that's probably had back surgery or they're not a candidate for surgery. The oral medications they're taking is not helping them. So, this patient, we're offering a pump to again get them a better quality of life, allow them to do the activities of daily living. A lot of these patients go back to work. They're able to do a lot of the things they couldn't do before.
That sounds awesome. When do you? There's a lot of things out there. Obviously, I mean, everyone knows there's a lot of technologies. When do you choose to use this? I mean, a lot of people know about stimulators. Obviously, there's a slew of different medications and other things you can do. When do you put this in your algorithm, so to speak, and how do you know when to go there rapidly? Like, do you start immediately if someone's having difficulty and they're having side effects with pain meds? Do you say, hey, you need a pump, or do you try something else before that?
A lot of this is patient dependent. Some patients really these days don't want to be on a lot of opioids to begin with. Their goals, if they're not benefiting from a couple of medications, may already be seeking other interventions for pain relief. And as pain physicians, that's where we come in to kind of give our patients a kind of a guide of when it's appropriate to consider both a stimulator and or a pump. In general, we like to try things a little bit stepwise with some of the medications, but we're probably less liberal with opioids than we were perhaps even 10 years ago. Definitely a few years ago. So if you think about that, and from that perspective, if people aren't doing well, if they're even getting opioids, and cancer pain patients are still getting opioids and you're still using that, what you'll see is that when the medications aren't as helpful as they used to be, the beginning signs of opioid tolerance for a cancer patient is when you had discussions for interventions. And for us, intrathecal drug delivery becomes a very good option. And clearly you want to have these discussions very early on a patient's care, probably both for chronic pain and cancer pain. For anytime you meet a patient, from our perspective, you want to introduce concepts of interventions, concepts of intrathecal drug delivery, so that they're not going to be surprised when it's come to that point. They're already familiar that this point may come. It's not the end of the line, but a beginning of perhaps better treatments. But the reality is you want to introduce these concepts earlier.
So, and I agree. I think that in non-malignant pain, if you look at the history, pump therapy used to be a salvage therapy. It used to be, people thought of pumps, after you tried everything else, after they failed oral opioids, after they failed everything, they're still on oral opioids. Let's try a pump, add a pump to that. So, that algorithm has changed in the last few years. What we found is patients benefit from pump therapy if you kind of move it up into that treatment algorithm. Once patients fail injections, they fail all the conservative therapy. If they are either had surgery or not a surgical candidate, in my practice, if they have axial neck or low back pain, I really kind of migrate towards pump rather than a stimulator. Again, I know there's a lot of other interventions out there. I know there's a Smile, there's a lot of fusion devices out there. I think that, these patients really benefit from a pump if they have really axial pain. They failed all the conservative treatments. And we've moved it up in our algorithm to, these patients are either off oral opioids or they're on oral opioids and they're not helping. So we wean them down. We do a trial, and then we, most likely the trial is successful, and we go ahead and implant them.
That's interesting. I want to touch back on that trial aspect,
Yep.
And when you get to that, we'll get to that in a second because when we talk about meds. But an interesting question: when you were talking about patients that it was end of life and kind of where they're at like a particular point where they need something just to make them more functional, quality of life in these malignant patients where they have cancer. How long do they need to have in terms of life expectancy to make a pump worthwhile? If they have a month left, is it worthwhile to put a pump in that patient?
What's been great about oncology in the last 10 years is our definition of end of life has dramatically changed. So we're not seeing patients who are the first time pain you have 3 months to live. Our diseases have been controlled much better in the last few years with oncologists. So our decisions are really changing to opioid tolerance and opioid diversion and opioid issues that are in the chronic pain population entering into oncologic patients because now they're using opioids long term. So I really don't have a conversation about intrathecal drug delivery at the end of life anymore. Yeah. I really start introducing these concepts, and I think Anjum really did a good job taking this home as we have so many new options. And this is the same thing is true in cancer pain. management. And it's wonderful to bring back a therapy that's been tried and true for many years, but to kind of invent its purpose and its place in our algorithms. And really, you're starting to see that it could be earlier on in some of the other interventions that we provide. And the same is true for cancer patients. For us, really, it becomes the opioid is becoming a problem either from a tolerance standpoint or diversion standpoint, probably less common. That's when we introduced the intrathecal pump. And I really don't have end-of-life conversations anymore. I would say most patients probably don't want to have that conversation, and you don't want to link end-of-life to intrathecal drug delivery. Yeah. Because what will happen is people will correlate the two, and in this patient population, we want to give them hope. And really, we might introduce concepts when the family says they're not enjoying their being with their loved one anymore that's suffering from cancer pain. That's when you talk to the family, look, this is the time to try an intrathecal drug delivery system.
I like that. Let's go back to it. Let's talk about the meds now. You were talking about trialing meds, and essentially what are you doing to start with them? How do you get them into the pump, and what's the first thing you look at?
So yeah, I mean, first of all, once this patient's failed all conservative treatments, they've failed injections, they're not a surgical candidate, or they failed surgery, we introduce a pump to them and talk to them about the pump, and the question is, why do we do a trial? What are we looking for in a trial? There's a big debate out there whether we should even trial or not. So what we're really looking for in a trial is it going to work? Is there efficacy behind it? Yeah. Can we convince the patient that this pump's going to work? Can we convince ourselves that it's going to work? And then some people trial for side effects, looking for different side effects with medications. So there are several different ways to do a trial. Some people do an epidural trial. Some people do a single shot intrathecal trial. Some people do a continuous trial, intrathecal, while they're in the hospital. Personally in my practice, I do a single shot intrathecal trial. However, per Medicare guidelines, I do place a catheter. So I just use a regular epidural kit. I access the intrathecal space and I put a catheter in, do a single shot bolus of fentanyl. And the reason I've chose fentanyl over morphine or Dilaudid or any other medication is fentanyl short acting. I can feel safe sending them home. If we look at the Polyanalytic Consensus Committee guidelines for trialing, I think that fentanyl was the PAC guidelines. Yeah, the PAC guidelines. So I can feel safe sending them home with an intrathecal single shot fentanyl trial.
Makes sense. What about you, Amit? Same thing.
Our philosophy on trials are a little bit different in cancer pain population. Sometimes our goals are really for comfort, and really we're looking at whether a certain drug might be more effective than another. So for example, an epidural trial with local anesthetic may be very helpful in this population. We've done a few of those over the years. So that if someone can get numb in a region of pain, then you can use the same medication, a local anesthetic, in the intrathecal pump. Some medications is nice to know has some chance of efficacy. For example, ziconotide is probably a reasonable thing to trial, probably because to deliver the medication takes some commitment. And so having an appropriate trial to see efficacy in a trial may be helpful to a cancer patient. But by and large, we're really trying to help our cancer patients. And a trial may be done for various reasons, but from a knowledge and intellectual standpoint, placing the pump is much more useful, and you don't get terrible amount of information from the trial specifically, because you have to remember, intrathecal drug delivery systems are a marvel of engineering. Yeah. It's hard to deliver 0.2 milliliters a day of solution. I mean, I can't do that.
Imagine pushing a syringe and that right.
Yeah,
it's really difficult to do.
Exactly.
So there's nothing to mimic it, right? Only the pump can mimic the pump at the trial.
Yeah.
And so to replicate that and some of the understandings that we have of CSF kinetics, really, what I've always feared is our trial is better than the pump. And we've had that happen many times early on in my career where they'll feel excellent with that trial, and the pump didn't replicate it because it works different and the feeling is different and the concerns are different. And what we don't want to do is build false expectations. We want patients to have the appropriate expectations so that you have a much more successful treatment.
Gotcha. And I mean, I assume there's multiple philosophies behind what to do in terms of bolusing or doing epidural catheters, and everyone has a rationale to understand what is best for the patient. But if someone is responsive to opioids, does that, and the amount that they're taking beforehand, does that factor into how much you give them, or is it more the trial or what you have data before that informs your decision? How do you know how much?
So in the non-malignant pain population, certainly if somebody's opioid tolerant, we will probably trial them with a little bit more. I'll use fentanyl in the most common population that's not opioid tolerant. I'll use fentanyl 25 micrograms.
All right.
Somebody that's on high dose opioids or even a cancer patient, I may use 50 micrograms. So it factors in, as far as, how much opiate the patient's been taking previously and for how long. So, most of our patients, we try to wean them before their trial. If we're successful in weaning them off of their oral opiates, then we'll do fentanyl 25 micrograms.
Interesting. When you wean them, do they go back into a lot more pain? Like, how do you rectify that?
That's a great question, because a lot of these patients, obviously they're looking for another alternative because what they're taking is not working.
Yeah.
So they're in a lot of pain already. And, their pain scores at 10 out of 10, whether they're taking their medication
Maybe
or
a
not.
20 out of 10 is usually what you hear. That's when you know it's bad.
So yeah, exactly. So, what we do is, I want them to be hurting when they come in for their trial. I want them for their pain to come back. So, we can really assess the trial. And what I tell these patients is, if the pump is all you had, we want to see if it's going to help your pain or not.
Yeah.
So, I'm sorry that you're hurting, but I'm glad you're hurting. We'll do this trial to see if it's going to help or not. Again, as Amit said, we don't want to build false expectations. So, I will always tell them that, because of the volume of medication that we use, you're going to get better spread, and the trial, we'll give you immediate pain relief, and we'll just have to work up with that with the pump.
But to some degree, I think with the trial, you're getting buy-in from the patient. Like they empirically see, oh, I am getting better to some degree. I mean, obviously the point of what you're saying is it may be more than what they're going to experience with the pump. But still, if someone's on the fence about whether or not it's going to work, the trial does, in some ways, give them an idea that it has the potential.
Well, and that's true. These patients are looking for something that's going to help them. And I've had several patients that have weaned off of their medication. We've done the trial, and that's the best they felt in 10 years or 15 years. They're able to get up and walk around, bend over, do stuff that they haven't been able to do for years. So, you got buy-in for the patient. When you get buy-in from the patient, more than likely, it's going to be a successful trial, a successful pump.
Yeah. What are the medications that you can put in? I know you guys have mentioned fentanyl. Can you just crush up OxyContin, put it in there? What can you
Please don't ever do that.
Yeah.
Well,
we wouldn't recommend it. Yeah.
What can you put in there? What are the meds that go in here?
Really, we both go back to the PAC guidelines, and I would encourage everybody to kind of review the PAC guidelines. So, what's FDA approved for the pump? What's FDA approved for the pump is morphine as an opiate, Prialt, or Ziconotide as a non-opiate, and baclofen. Yeah. So, those are the three drugs that are FDA approved. So, I always start all my pumps with morphine. And then if for some reason they have a side effect, whether it's lower extremity swelling or itching, or it doesn't work, then I'll move to something that's off-label, which is, first option's Dilaudid. And then I may use fentanyl. I've also used bupivacaine in the pump before. I know Amit, I think, uses a lot of bupivacaine. I'll use clonidine as a secondary. But, if you look at the PAC guidelines, it will kind of go through the number of drugs, the different drugs that are used and kind of where they fall into their algorithm.
When I was in medical school, all people would talk about would be the art of medicine. That was a big catchphrase 20 years ago. And I remember taking cardiology courses, and when the blood pressure went up, you gave a blood pressure medication. When it went down, you gave a different medication, an exact dose you're supposed to give it, and it seemed very mathematical. You do surgery, and it seemed very, like, you do the same process every time, the same way. And there's very few things that's truly art.
Yep.
But intrathecal drug delivery is still art.
It's an art.
You're talking to two people who are very experienced in intrathecal drug delivery, and we have completely different algorithms of medications that we choose that you've touched on. We can introduce some of the off the beaten path medications, ketamine, methadone we've seen before. People have tried, even gabapentin a few times a long time ago. They were testing these different medications. The doses aren't set. We don't know all the variables associated with a patient to get the correct dose for every patient. It's really an art to trying to dose these patients. There's so much technological difference between the devices. There's so many variables we don't know. It's become an art. And really, the people who do a lot of this on a regular basis are like little maestros. They understand to see, to draw the painting that looks like Guernica afterwards. You're like, oh, it's brilliant. And so there's a art to it, and that's the joy of pain medicine. I feel like we've lost some of the art in stimulation. Not that I'm discouraging stimulation, but when's the last time most people programmed a stimulator? They place them in the same location, and it's done. And the waveforms may be changing, but they're changing internally. But the medical physician really isn't doing that aspect of it. But in intrathecal drug delivery, there's still a really nice art to it. And really, as you gain your experience, you really can share your artistry, because it's going to be different from Dr. Bucks than it's going to be from Dr. Gulati.
I hear that art's going for NFTs now. Are you going to NFT this? Like your numbers?
Yeah,
you're just
it's
going
a generation before me, but if someone wants to sponsor me,
like writes down your residents writing down the numbers.
Right now, I'm going to ask my fellows. NFT stands for.
It's just like in the background. I'm selling everything. I'm selling everything on its writing.
Yes.
Let's talk about.
I still believe in painting with acrylic and oil.
Let's talk about something a little bit more about the engineering to some degree of the pump. How much do you give? It's obviously such a small amount. Where do you start? I get the sense that kind of is the heart of what you're giving and how much you're getting. Is that right?
Yeah, I mean, really, it's whatever your starting dose is what you're comfortable with. Everybody talks about microdosing.
Yeah.
Microdosing,
which is different than the drugs that normal people microdose, like shrooms and stuff, right?
Yeah, exactly. So, microdosing or low doses is the lowest dose at which the patient gets efficacy. So, where I'm starting, usually I start with morphine at 0.25 milligrams a day. And then I'll increase, and everybody has their comfort level increases. I usually use 10 to 20%, about every 2 weeks, to see if they, as we increase to get efficacy. I would say, half my patients probably get efficacy at less than half a milligram a day.
Oh wow!
Yeah, so they do real well with it, and I think part of that is weaning them off of their oral opioids prior and managing expectations prior to that.
Do you think that in some ways when you do that weaning process that there's a tolerance that's developed to the opiates, and you are in some way at least breaking down that tolerance to some degree? I don't know if that maybe is the right way to describe it, but you're bringing them back down to a normal dose of medication that may help with their pain, and when you put them on the pump, they're like, oh, this is just as effective now.
Right, absolutely. I mean, I think that all of these patients that have been on long-term opiates have developed some sort of tolerance. Yeah. So getting that oral opiate out of their system is somewhat breaking down that tolerance. There's different studies out there that, how long does it take to get rid of tolerance? We don't know how long. Yeah. But as we get it out of their system, we're starting to break it down. So I think that's where these patients get benefit. They've got the pump. It's stronger than, the pill that they're taking. It's more potent. It's going right to the source of the pain. So, a lot of these patients are getting significant benefit as soon as we start the pump.
Probably also piggyback on that, perhaps the biggest technological advance with these pumps is the pumps are very simple. They just give a constant volume of solution at a very low flow rate, but you can give a bolus of it as well. So we're talking about tolerance of opioids, and that tends to happen when you have opioids circulating around the clock, so to speak. And we've seen time and time again with cancer patients, and probably chronic patients too, that a bolus of a medication may be even more valuable than the actual regular infusion of it. And so these devices have become very clever in delivering these boluses. And I've seen that's been a dramatic change in the efficacy of the device being utilized correctly for our patients, whether they're chronic or cancer or complex pain, I like to say. I think that consider that part of the technology as really a really good advancement. Has been very beneficial to our patients.
Can you just tell me, is there anything particular else that people should know about FIDDS? Is there anything else you guys are working on or anything interesting that's going on?
We're gathering information, and it was one of the things we're going to work on is what other fields are using microdosing, and kind of disseminate that information and start going to their conferences and talk about how to manage those, how to manage a pump for their particular disease. But the first step is really to figure out what other diseases are being treated with microdosing. As it turns out, there's a significant number of other disease states, diabetes. There's other disease states that have microdosing as part of their routine treatment algorithm. And there are other diseases that may benefit, but other people have not looked at intrathecal drug delivery yet that we haven't even thought of. Maybe Alzheimer's is one of them, but maybe there are other neurologic conditions. We're thinking about using intrathecal methotrexate for leptomeningeal disease and these kind of things in drug dosing. So there's a lot of different things that we are trying to do, but the main initiatives are going to be educational and guidelines resource for the next few months.
And also we're working on some research initiatives as well. I mean, we all practice by evidence-based medicine.
Yeah.
So there's not a lot of evidence out there to show the benefits of intrathecal drug delivery, especially for non-malignant pain. I think there's some for cancer-related pain, but for non-malignant pain, there's not a lot out there. So we'll work on some research initiatives to show the benefits of intrathecal drug delivery for non-malignant pain. It kind of helps us as practitioners. Also will help the payers to pay for it. Which is a big thing.
It's actually very important.
You can't.
We actually have not talked about those initiatives, but we're definitely working on initiatives to help insurance companies see the value of intrathecal drug delivery, compound medications. That's a very big part that we've kind of underscored. But for this to continue in the United States, at least, we have to show value propositions, and the future research studies have to have an economic outcome that needs to be discussed for this to be successful. And that's very, very important, actually. That's the one serious comment I'm going to make.
I'm going to see you two protesting in front of Capitol Hill. It's just you two.
Oh, yeah, exactly. With our pumps in hand.
You got a sign and everything.
Yeah.
When is the TikTok coming out? Is that happening soon?
What's that?
All right. On that, we'll call it. It was great talking with you guys. Thanks for sitting down with me. And hopefully, people learn a little bit more about pumps and they get interested in coming to FIDDS and really getting in the nitty gritty of it. Thank you for sitting down.
Thank you for having us. Thank you for OuchCast and WAPMU.
Yes.